Hello, I'm Dr. Stephen Mary. I'm one of the proceduralists here at the Mayo Clinic Rochester Primary Care Procedure Clinic. And today we're going to be learning how to do peripheral nerve blocks for headache. These nerve blocks work for essentially all headaches. So the crazy thing is, if you're seeing a patient in your primary care office or in the emergency room, an urgent care setting, wherever, maybe you're just at home and a relative has a headache, these are highly effective to take away headache. In fact, in the over 12,000 or so blocks I've done, I haven't seen a patient who, once the nerve was blocked in the area of the headache, still had a headache. So today you're going to learn how to do the blocks, but one of the things I want you to be sure to do is to confirm that you actually did a nerve block. This is not a trigger point injection. This isn't a blind shoot it somewhere injection. This is a nerve block. And so you can test to make sure that the nerve that you intended to create anesthesia in is indeed numb. And we'll see that as I proceed with our patient, who's one of the emergency medicine residents who's giving up of his scalp generously to show you how to do this in the next few minutes. I'm a strong believer that if you're going to, as I already said once, but I'll say it a second time, do nerve blocks, you'll want to confirm that you got a nerve block. If you did not achieve nerve block, then re-inject the patient until you achieve nerve block. That's how this will be successful. Certainly acutely, that is why we confirm nerve block, because immediately after achieving anesthesia, the patient's headache in that area will be gone. The pain is felt in the nociceptors of the scalp. Yes, there's feedback to the trigeminal cervical complex in the brain that downregulates the migraine, but in terms of pain relief, immediate pain relief is achieved once the nerve in the region of the headache is blocked. So I would have asked this patient, where is your headache? And if their headache is just left occipital or left temporal or left frontal, then that's the area that I block. Now, there are some who would say, oh no, you need to just block the greater occipital nerves. We don't have any good evidence that doing more than that is needed for either acute or prophylaxis. And that's true, the studies are lacking. But in my experience, for acute relief, you need to block the nerves in the area of the headache. So today, we're going to assume and base what I'm doing on the fact that Obadi is suffering from a holocephalic headache. His whole head hurts. Maybe it started here, but it's generalized. And so I'm going to be blocking all of his nerves. And that's commonly needed for a chronic migrainer. You can block the occipitals, the greater occipitals, and get some relief, but oftentimes there's residual pain that you can immediately make go away if you block the nerves in the area of the headache. So, how do we start out? Well, we start out in this position, face down, forehead positioned on a couple arms so our patient can breathe. So we're going to start here with the greater and the lesser occipital nerves. Our first point of reference is the inion, or the occipital protuberance. Now, how do I know this bump here is Obadi's inion? Well, I don't until I palpate some more. So this is center. I'm looking at spinous processes. I'm coming up the back of the head. There's a bump there. But then I need to feel down here for nuchal edge. If the nuchal edge is 3 centimeters inferior to that bump, that's the occipital protuberance. If it's somewhere greater than that, I've got to refeel. And some patients won't even have as big a bump here as they may have right down there at the bottom of the nuchal edge, less commonly, or more commonly another bump up here that may be even bigger, but 3 centimeters above the nuchal edge, felt with firm palpation, and that then is our inion. So where is the location of the greater occipital nerve? Well, the greater occipital nerve begins at C2, right? It's the dorsal ramus of C2. So they split, come out between C1 and C2. That dorsal ramus that turns into the greater occipital swings inferior slightly and laterally, crosses below the occipitalis capitis, obliquus capitis inferior muscle, and and comes above it about 3 centimeters from the midline, and then comes back towards medially, traveling at about 1.5 to 1.3 centimeters from the midline until it crosses the nuchal edge at 3 centimeters below the inion. It can be blocked there, 3 centimeters inferior, 1 to 1.5 centimeters lateral to the inion. That's block spot 1. The next place we block it is actually my preferred place to block it, and that's 2 centimeters inferior and 2 centimeters lateral to the inion. And again, we can measure that. Might as well take advantage of tools like that to be more precise. So there's 2 centimeters inferior, there's 2 centimeters lateral. And then if we use a pen like this, or here in the procedure clinic, we use an ear speculum, and that makes a really nice target that we can then inject. The next place we inject, so this is our first point of injection, my preferred one, 2 centimeters inferior and lateral. It tends to be the same size as a thumbnail, base and width. So if you don't have a measuring tape, you can use your thumbnail. And so we could go to the left and say, oh, there's going to be his left greater occipital nerve. The distance between those two should be 4 centimeters, and indeed it is, since we're 2 and 2. And then we're going to do this other one over here too. Notice that what Crystal is doing is not rubbing it, because in a person with a lot of hair, that would just get hair all in your way. You wouldn't be able to see. Usually I leave my fingers right there so that I can continue to sort of keep that area clear of hair. And then I let the patient know we're going to start those nerve blocks. Just ignore me is what I say, because saying it's going to hurt makes it hurt more. And then I drop it right in. I come off just a millimeter or 2 off os, or the bone, and then put in a cc.5 of injectate. Cover it up, or my assistant covers it up, and we come right over here, drop in, down to os gently, come up a millimeter or 2, and inject 1.5 cc's. Now, you can, if you wish, for increasing your success rates, you can fan it out a little medial and a little laterally, but it's perfectly fine to just target where you know the nerve is and drop in. And most of the time, within 10 to 20 minutes, numbness will begin to appear distal to the injection site. So let's move now to the lesser occipital nerves. The lesser occipital nerves are located 30% of the distance back from the mastoid toward the inion. So here we are at 110 millimeters for a body's mastoid to inion length. And then, so 33 millimeters back from 110, or roughly a third. If you want to eyeball it, fine. But if you want to measure, that's a little more exact. So there we are. And that'll be about 1.5 centimeters in from the hairline in most patients. Or you can simply feel the mastoid, and there's the posterior mastoid, and I can palpate that that is right where that mastoid comes up, and that's where the nerve's going to be. The course of the lesser occipital nerve, like the greater, comes out of C2, so between C1 and C2. It passes laterally to the posterior edge of the sternocleidomastoid before going up along the posterior edge of the sternocleidomastoid. You can also block it down there at the posterior sternocleidomastoid if you want to use ultrasound or along its course. Here, it's coming up onto the cranium, and so it's a very safe place for these peripheral nerve blocks to do it over the bone. So we're going to prep that again with just a little wiggle prep of alcohol, then drop in for a visit with our injectate. I got a touchdown on os there, come up just a little bit, and put in 1.5 cc of injectate. So we're going to do the same measurement so you can see this real time how this works. When a patient comes in and I'm doing all 10 nerve blocks, we've got that Indian right there. My tape measure is there, or if you want to just eyeball it, feel free. Again, Obadi's dimension is 110 millimeters from Indian to mastoid. 30% of the way back is 33. So I come back to 77. I make my mark right there. There's where that nerve is coming from behind the sternocleidomastoid up onto the posterior lateral scalp. We're going to prep with a little bit of alcohol right there. And then again, anesthetic is dropped in. I use bupivacaine 0.25 or 0.5, whichever you'd like. With 0.25, that generous 1 cc per kilo safety means you can use a lot of anesthetic. Now we're going to block the auriculotemporal nerve, which comes out of the superior posterior fossa of the right above the ramus, mandibular ramus, where it sits in the maxillary fossa, and then heads up right in front of the ear cartilage before it divides into multiple branches in the temple. You can get it down here, right at the midpoint of the tragus where it's coming out at the TMJ. However, there you also risk blocking the facial nerve. So let's go a little bit higher. So we block at the superior reflection of the tragus. So there's your tragus. I push it forward. I see that skin fold right there, and I make a mark right there. That's going to avoid the facial nerve and yet get the trunk of that auriculotemporal nerve before it divides quite well. Now, there is a superficial temporal artery that's a little bit deep to it and a little bit anterior to it in most people. Do not worry about that. Yes, it's a little bit frightening to have such a vessel underneath you, but it's completely safe. And so we mark right there. There it is. If that fails, so he doesn't achieve anesthesia in 10 or 20 minutes, he's already said that the whole back of his head is numb, but we'll check that before we finish. So if we don't achieve numbness there, then we'll go just about a ½ centimeter right in front of the helical cartilage right there, make a mark and inject there. But this is our standard place right there, and probably 90–95% of the first attempts here are highly successful. Okay. So a little wiggle prep with alcohol, and then I brace so that I'm coming in right at that point, injecting at a depth of a ¼ centimeter for someone that's not fluffy. If someone has a bit of extra weight, then I'll go to a ½ centimeter, and I inject 1 cc right there. And go. So now we're going to progress to the forehead and densely block the forehead. Again, if his headache wasn't in the forehead, I wouldn't be doing these nerve blocks. But Obadi's headache is everywhere, so we need to block the forehead as well. So where is the supraorbital nerve? Well, it comes out at a very varied set of locations. There's 2 branches, right? So there's the medial superficial branch and the lateral deep branch. In most people, the superficial medial branch comes out of the notch right above the forward-gazing pupil, just to the medial aspect of it. The deep branch often comes out of a foramen, and sometimes the medial branch with it comes out of a foramen that is, on average, somewhere around 0.25 centimeters above the supraorbital ridge. And so if you've had trouble with dense blocks with your supraorbital blocks because you're only blocking the notch, this is the reason why. You've often noticed that you're not getting the lateral aspect of the frontal scalp. And so here's the way to do the 2 with 1 injection. So we have the patient gaze upward to the ceiling forward. I notice his pupillary location. I come up a ¼ centimeter above the supraorbital ridge. The medial aspect of the forward-gazing pupil is my mark, because that's where most of the medial branch SON will be, and then I do the other side and make that mark. Now I've got my entry points for the two supraorbital blocks, and then I palpate for the supratrochlear nerve. You can feel the neuroforamen right underneath the edge, halfway between supraorbital and medial canthus of the eye. There's a little indentation there. That's the supratrochlear neuroforamen, and we'll mark that. We'll come over here, palpate that one. We'll mark that. And now we've got our 4 block sites ready to go. So just like for the others, we prep with a little bit of alcohol. And then I place my finger of my non-dominant hand underneath that supraorbital ridge so that there's no swelling of the eyelid. I brace my finger. I enter through the eyebrow right onto the os. I'm now 1/4 centimeter above the edge. I inject a 1/2 cc. It's actually going partially subgaleal. The supratrochlear, again, I put my finger inferior just above the lid so he doesn't get any lid edema. I come in through the medial eyebrow at about a 45. I drop the tip just right down underneath my finger on the os and put in a 1/2 cc, and that's the supratrochlear block. And then we push down on these hard because there is a supraorbital artery that intertwines with the supraorbital nerve, and we don't want any bleeding from that. And so we'll put pressure right there, nice and firm. And as I tell my assistants, we want to see your fingerprints when you're done. That hard for 2 minutes to prevent a black and blue eye. So let's do this one more time. Again, we're going from left to right because we've got to do finger twister to cover up the places where we've injected. So there's supratrochlear, halfway between medial canthus of eye and the supraorbital nerve. There's the medial canthus of the eye. It's going to be located there. You can palpate that neuroforamen right underneath the supraorbital ridge. We'll again prep that with a little bit of alcohol, please, Crystal. And again, my finger comes underneath. I brace. I come in through the medial eyebrow. I drop the tip there just right inside my finger against the os, and I put in a 1/2 cc. So I'm covering up where I've injected over there with my thumb. I'm using my finger again to prevent lid edema distal or inferior to the injection point. I've made my mark 1/4 centimeter above the supraorbital ridge, but I've pulled the eyebrow up, so I'm injecting through the eyebrow. At that same point, I drop in right against os, so I'm injecting subgaleal because that's where the deep branch often is located at this point. I finish that injection, I lift up slightly and drop below the supraorbital ridge for another 1/2 cc. Then I cover up all of these. So we hold these for 2 minutes to prevent bruising. And then when I take the fingers off, really should see some fingerprints there that say, oh yes, I've been holding it really nice and tight. When we're done with all the nerve blocks, and at this point, Obadi has already said his head is numb, but that's not, in my book, good enough. We need to check. So then you can take a sharp objects like the end of a ballpoint pen, or we routinely use the same marker and we poke. And what I will do is say, okay, Obadi, we didn't block that. That should be sharp. That's the comparison. Does it get dull as I come up here?
It does.
And does it stay dull there?
Very dull.
And does it stay dull there?
Dull.
And is it dull here?
Yes.
And here? So we've got the medial branch, the lateral branch, the supratrochlear, medial branch, lateral branch. Whether to use corticosteroid or not, the trials that have looked at corticosteroid use and whether it reduces headache intensity more than just anesthetic or prolongs headache relief prevention, prophylaxis have been inconclusive. There's currently a randomized trial underway here at our institution to determine, I think, more definitively whether they are helpful. For the present, what we do know is that in cluster headache, and therefore in other autonomic headaches, we continue to use steroid because there's at least some good evidence that it's helpful in reducing future occurrence of headache. So if your patient has autonomic signs of redness of the face on the ipsilateral side of their pain, tearing of the eye, nasal congestion or runny nose, again in the face often with those symptoms that they think are sinusitis, but really it's migraine, then I would use steroid. But if they are not having any of those autonomic symptoms and they're in your ER or in your office, it's simply done without steroid. And then you might want to use Cook's postulates and just see if adding steroid prolongs their prophylaxis. Over the many years, 20 years I've been doing this and over 12,000 or so blocks, I have a goodly number of patients whom I've twice done without and done with, and they get longer prophylaxis by a month or two, and so we continue to use steroid for those individuals. But that's how to determine whether to use steroid. Thank you very much for listening to this video. If you have questions, please don't hesitate to contact me. My email address is Mary, M-E-R-R-Y, like in Christmas, .Stephen, S-T-E-P-H-E-N, @mayo.edu. I'd be happy to answer your questions or explain further our methodology of these nerve blocks for headache. Thanks for tuning in.